Hi everyone, my name's Sam Cooley. This is a recorded presentation for the DCP Annual Conference 2021, and I'm going to be presenting the findings from a study we recently completed at the University of Leicester, which explored the organisational culture in clinical psychology and how this culture can impact our choice of therapy environment. So just to give a little bit of background, last year at the DCP conference, I presented the findings of a metasynthesis where we explored the experiences of practitioners and clients who had practiced talking therapy in alternative outdoor spaces. And this review has since been published in Clinical Psychology Review and also developed into a BPS guidance document on outdoor talking therapy. The themes that came out of the review were organised into this framework, and this included the various ways that therapy is enriched through being in an alternative outdoor space. And this included benefiting clients who found conventional indoor therapy difficult to engage with. And one of the themes I wanted to pick out as well was the organisational barriers that were reported by practitioners who didn't always feel like they had a choice of setting for therapy depending on the service that they worked for. And this resulted in a disparity across professions where the option of having therapy outdoors was most prevalent in counselling and psychotherapy professions. There was very few clinical psychologists, and also most practitioners worked in private practice rather than public health services. So the aim of the present study was to further understand how the organisational culture in clinical psychology may prevent or enable a choice of therapy environments. And so I collected data using interviews with leaders and experts in clinical psychology. And these were participants who were heads of services, they were directors of declin training courses, they were also people who had developed therapy models that were used in the profession. And using an informed grounded theory approach, this allowed existing models to be incorporated into the data. And one of these models was Barry Mason's model of safe uncertainty with the 4 quadrants. And I'll show how this model was applied to the data in this next slide. So it was found that a practitioner's stance towards the choice of therapy environment can fall into one of these 4 positions. And environmental safe uncertainty was considered the favourable position to be in, which was described as a position of openness, curiosity and collaboration with the client regarding the therapy environment, including being open to the possibility of other environments being more conducive to therapy. So this might have included the practitioner and client reflecting on the impact that the environment is having on the therapy. And I'm thinking about whether perhaps stepping outside of the therapy room into alternative spaces might be beneficial. But what was important was that any alternative space for therapy, whether it be outdoors, in nature, or in a more public space, these alternative environments had to remain safe and conducive to therapy. Otherwise, there was a risk of falling into a position of environmental unsafe uncertainty, which was defined as venturing into unfamiliar and potentially hazardous therapy environments without due care, without having a rationale, or without having the relevant expertise or informed consent from the client. And so this might be, for example, deciding to take the therapy up a mountain without there being any rationale for doing this, or perhaps without the practitioner having the necessary expertise to be supporting therapy in this environment. In contrast, environmental safe certainty was defined as where a client and practitioner have a fixed or preferred therapy environment without considering the potential benefits of alternative environments, or the practitioner not involving the client in this decision-making process. So examples might be a practitioner who believes that an indoor consulting room is the best environment for therapy, and therefore only ever offering this environment to their clients. Or on the flip side, it could be a practitioner who believes that the outdoor environment is the best and only setting that therapy should be provided in, and only offering this to their clients. And the data suggested that this more fixed position works well when the client is aligned with the fixed environment that's chosen. But when there's an incongruence between the client and this fixed environment, this is where the therapy could risk falling into a position of environmental unsafe certainty. And this was defined as where the rigidness with the environment becomes detrimental to the client. And this could lead to either the client not being able to access therapy in the first place, or disengaging from therapy. The themes that came out of the study were organized into organisational influences that either support practitioners in maintaining this position of environmental safe uncertainty, or in organisational factors that push practitioners into a more environmental certain position, which can be safe or unsafe. And these were influences such as the subculture within particular teams, or the accessibility of alternative spaces. It also included themes around the challenges of operating within a medical or business model environment. And I'll give a few examples of some of these themes. So the weight of tradition, both within a practitioner and within a service, was one theme that was suggested as sometimes pushing practitioners into this position of more environmental safe certainty. And this was described by this participant as, you are constantly working with the assumption that what we do is safe and good, and therefore everything that you're trying to change people to, you've got to prove overwhelmingly that it's somehow significantly amazing. Whereas we could be sitting delivering something that's inherently bad, and people wouldn't see that because they're already doing it. The most common reason that people do what they do is because it's the way they've always done it. So it's such a powerful bias in how people approach their work. There was also a theme around internalized risk, which was another theme that was suggested as restricting at times a practitioner's choice of alternative environments for therapy. This participant described that, I think we are quite risk averse, often in a way that's not actually helpful to clients. The idea that you can do psychotherapy without risk is complete nonsense, because if it's done right, it has the power to transform someone's life and change it for the better. But any intervention with that degree of power, if you make mistakes or you get things wrong, it can cause harm. But then you can't do anything that doesn't have that risk. The crucial thing is that people need to take informed consent if they're capable of consent and that they know the risks. But a lot of practitioners internalize the barriers, and they imagine that, oh no, they wouldn't like that, I better not do that. They become their own policemen and have this internal finger wagging. Oh no, you mustn't, no, it could go horribly wrong. What if something happened? In contrast, the pandemic was felt to have encouraged practitioners into this position of environmental safe uncertainty as they were forced to explore alternative environments for therapy. And this participant described that, if you'd asked me pre-COVID, I probably would have had more reservations about therapy outdoors. It's got me thinking more about the boundaries of therapy and how you can maintain those and how you set those up. If somebody had said to the NHS, you can start doing your therapy online, they would have put up every barrier known to man. Whereas out of necessity, we very, very quickly got going. and they turn it around. So they can turn it around, but it took a pandemic to do it. And finally, this theme, hard heads, soft hearts, was described as a way that clinical psychologists can explore alternative environments for therapy whilst maintaining a degree of safety. And participant 3 described it as, the really important ambition in being a clinical psychologist is to have a hard head and a soft heart, but don't get them the wrong way around. What that means is you have compassion and an ability to reflect and think about what's going to help the person you're working with, but you don't give up your critical faculties. So if you follow that through, it means that you're confident enough to leave the consulting room if you're keeping a critical eye on whether it's going to work and whether the client is responding and wants to do it. So just to finish with some final conclusions and points of discussion. Number one is that a person-centered approach to therapy includes considerations regarding the physical environment, and this might mean adopting this position of environmental safe uncertainty. Number two is that we need to address inequity in outdoor therapy, given that currently the option of therapy outdoors is mainly absent from most public health services. And number three is that future research is needed to look at the impact of implementing greater choice of therapy environment versus operating with a more fixed position on the choice of therapy environment. So thank you very much for listening, and thanks to those who have supported this research in one way or another, including the Churchill Foundation, who funded the project that I presented today.